about the change in the approach to what we've previously talked about, fabricated or induced illness, and before that were many other titles, including Munchausen by proxy, etc., etc. The Royal College of Paediatrics has developed a new kind of approach to this, and is looking at splitting it up into cases where there are medically unexplained symptoms or perplexing presentations that don't seem to add up, as opposed to just definite fabricated or reduced illness. It does include both, and hopefully we'll try and make it clear what the difference is as we go through. The Royal College has stipulated what the essential principles of the new approach is. It's the importance of looking at the functional implications of a diagnosis rather than the mere fact of the diagnosis. So what should the diagnosis mean to how the child would be able to perform and act and so on. The essence of FII is where the parents are focusing on trying to convince doctors about the parents' erroneous view of the child's state of health, which isn't the correct state of health. This behaviour may or may not include deception. I mean, sometimes the parents may believe exactly what they're presenting and have a deep conviction that they're correct. But sometimes they may be deliberately trying to deceive the medics. Parental behavior may be motivated by anxiety, the erroneous belief about the child's state of health, and or gain for the parents. That might include being able to obtain disability and living allowances and so on. Or it may be that the parent doesn't want the child to go to school because the parent wants to keep the child at home. There should be a move away from the inability to inappropriately challenge parents because of concern about FII, except where challenging would put the child at immediate risk. So the old days of FII, what used to happen is somebody had concerns, they would contact either someone in health or social services, a meeting would be held, and the parents were kept out of it. And the idea now is to involve the parents from the very start so that we don't get into such an adversarial sort of predicament between the parents and health and social services and or the police. Next slide. Alerting signs of possible FI must, however, be considered and investigated appropriately, but the emphasis should be on the harms occurring to the child rather than the need to confirm evidence of FII. So the welfare of the child is always at the centre of the discussion, as it should be according to the Children Act. If there is a criminal investigation, then the needed investigation should be incorporated, and this might require cooperation between senior managers of various agencies in order to make this effective. Unless illness induction or deception are found, establishing FI depends initially on clarifying what the actual state of the health of the child is. And that's what this new approach is about, is trying to clarify really what is the health of the child rather than what the parents are presenting as the health and state of the child, and then gauging the parental reactions and responses in the light of these findings. Okay, next slide. It may be necessary to independently observe what is reported. For example, if the parent is saying that the child is has to be, say, in a wheelchair or whatever, but at other times the child can be seen to be running around the neighbourhood, and then clearly that may help to clarify the situation you're in. As I said, it's the focus is now very much on, is there harm occurring to the child, and does that present any immediate or serious concerns about their health and welfare? We've just been hearing about professional curiosity, so I won't dwell on that. Then, unless there's a significant risk of immediate serious harm, there should be a need for sharing information between different professionals involved in the child's life. But this should also be discussed with the child and young person and their parents, whereas in the old protocol for FI, they would be excluded from that as the FI investigation was progressing. And I said it should be done in a non-confrontational manner. And the idea is that, say, for a medic saying, well, to the parent, look, I don't really understand exactly why you're saying child's got these symptoms, or how you think the problems are. It doesn't seem to, there's something that's confusing. We need to clarify that, rather than saying we don't believe what you're telling us. It's kind of saying, well, we hear what you're saying. We need to try and get to the bottom of it. Try to work towards a solution. The next question, and next slide, please. Next thing, as part of the new protocol, is that when we're investigating these cases, if we stick to the ones particularly where it is thought that it is more of the perplexing presentation type case rather than the frank FII, there should be a health and education rehabilitation plan agreed by the professionals and families. And this should take place even if social care aren't already involved. There needs to be honest communication with professionals, unless this will place the child at serious risk. And of course, it's always difficult, when we get these sort of statements and things, exactly what do you mean by the risk of serious harm? It's like when we're doing child's serious case reviews and so on, whether they should become one, and we're looking at the national sort of guidance to what cases should be considered for an SCR or a child safeguarding practice review, and we often have debates in the SCR group of what evidence we have that serious harm to the health of the child has occurred, and it's a sort of problem definition of exactly what is serious to somebody may not be serious to others. Now, the other thing is that the responsibility for initial management and collating the health involvement is with the responsible consultant. And the responsible consultant, however, should seek advice and support from senior colleagues and tertiary specialists where involved. And for example, in my safeguarding roles today, I'm often contacted by other colleagues, both within the community and the hospital and from the CCGs, to discuss cases and to add my experience to what is being considered. Next one. Okay, so there's new terminology now. We're talking now not necessarily just FII, medically unexplained symptoms, and the symptoms the child's complaining of may be presumed to be generally experienced, but they're just not experienced by any known medical pathology that we have to date. The symptoms are likely based on underlying factors in the child, which may be of a psychological nature, and this has to be acknowledged by both the clinicians and the parents. They can be described, we sometimes talk about functional disorders, and for example, particularly with young children with abdominal pain, we talk about functional abdominal pain, which is sometimes then thought to be part of what we call abdominal migraine. And there may be abdominal bodily sensations that cause pain and disability by affecting the normal functioning of the body. The parents and health professionals need to now work collaboratively to achieve evidence-based work in the best interest of the child and the young person. So, the idea is we're now saying, look, we understand that there are concerns, you've got concerns, your child has concerns. We don't necessarily understand exactly what's going on, but we're going to try and get to the bottom of it and get a resolution of the issues. Moving on. So perplexing presentations describes the commonly encountered situation when there are potentially alerting signs of FI, but they may not amount to full FI. The actual state of the child's physical, mental health, neurodevelopment is not clear, but there is no perceived immediate risk of serious harm to the child's physical health or life. If there is an immediate serious risk, then this does immediately move into the FII spectrum, and we need to take action if we feel that there's a serious risk to the health of the child. The essence of the alerting signs of perplexing presentation, discrepancy between reports and presentation of the child and possibly independent observations of the child. Also, implausible descriptions of the parents claiming that this sort of symptoms occur, and there's no possible way that that could be happening. Moving on. FII, however, is a situation which is quite different. Well, not quite different, but is a greater extension towards the harming area, where the behaviour and action of the parents is carried out with the aim of convincing doctors that the child's state of physical, mental health or neurodevelopment is impaired, or is more impaired than is actually the case. And this is often part of the problem with a lot of the FI cases which I've had to deal with over my 40 years doing safeguarding, is that there may well be significant medical problems, the child diagnosed medical problems the child has, but then there's other symptoms being added into it by the parents, and it's trying to sort of dissect, yes, well, actually this could be related to their known medical diagnosis, but this extra bit that seems to be added in, pushed in by the parents, is what we're really concerned about. Sometimes the parents may not necessarily intend to deceive, and their motivations may not be initially evident. Sometimes they are intending to deceive, and those are probably the more dangerous cases, where the parent is literally trying to trick health and other professionals into taking actions that aren't in the child's best interest. Illness induction or fabrication of symptoms or deliberate induction of illness in the child is, however, physical and emotional abuse and should be considered as FII as opposed to a perplexing presentation. If there is evidence that the child's motivation for harming the child is to convince doctors that the purported illness is in the child, whether or not there are recurrent presentations to health and other professionals, and this can particularly be important in cases of suffocation and poisoning, because when these sort of cases occur, and I'll show you an example in the slide later, the outcome can be very serious or even fatal. The other harm that we're always very worried about, the medics end of this, is the harm or illness caused by unnecessary medical examination or treatment that doctors, in working what they feel is in the best interest of the child on the basis of the medical the information that's being provided by the parents and carers, and children get put through unnecessary, unpleasant and potentially dangerous investigations. Okay, next slide. Okay, I'm just going to show you just a few cases, just to give you a flavour of what FII is, as opposed to what are perplexing presentations. This was a case I dealt with when I was working at St Mary's, London, when I was a registrar, and it was a 4-year-old girl with a family history of inflammatory bowel disease, Crohn's and colitis, and she presented with abdominal pain and rectal bleeding. And the mother showed good evidence of the rectal bleeding by bringing in several pairs of the girl's knickers stained with blood. However, when we were doing the clinical examination, it was relatively unremarkable, and particularly inflammatory bowel disease, when you do a rectal examination, usually there are clinical signs such as rectal fissures and so on, which weren't present. But on the other hand, she didn't like abdominal palpation and would wriggle and sort of moan and groan when trying to palpate the abdomen, which is a sign of inflammatory bowel disease. So we're a bit confused. There's a typo here, because it's meant to say that the nurses never see any PR, per rectal bleeding, on the ward. When they were changing, they never found any blood-stained underwear. And so we had the bright idea of analysing the girl's underwear, and it wasn't stained with the child's own blood group. It was identified as the mother's own blood group, and what she was using was saved up menstrual blood to stain the child's knickers to try and trick us into doing unpleasant, unnecessary investigations for inflammatory bowel disease, which might include colonoscopies, barium enemas, and so on. So fortunately, we managed to pick this up before the child was put through horrible investigations at the time. This was another case for the Royal Infirmary, trying to give you the sorts of things that parents will get up to. Child had previously had epilepsy, but had been taken off medication because the seizure seemed to have stopped. And then she was admitted drowsy to the Children's Hospital and thought might have meningitis. But she then, sorry, it was a he rather, not a she. He collapsed with a respiratory arrest in a cubicle in the children's ward. He was successfully resuscitated, thank God. And there was no obvious cause for the arrest. But then on a urine toxicology screen, which we always do those sorts of things, if a child suddenly arrests and we can't think why they should, and we found high doses of anticonvulsants. And the hospital stopped the anticonvulsant medication quite a number of months before, but the mother continued to get a continuing supply from the GP practice, and then gave a massive overdose, which caused this arrest. This could have obviously led to the death of the child. The result of that was a change in practice that GPs were to be alerted for confirmation that any letter from the hospital saying we've just reviewed this child in clinic, we've stopped their anticonvulsants, we were asking for confirmation back from the practice that that had been acted on and had been taken off repeat prescriptions and so on. Because back in the old days, often letters in the hospital would be, arrive in the practice, would get sort of just filed by the administrative staff and the GP not reading them at the time, and that would have led to the potential of these cases occurring in future. Right, another one. This is perhaps the most alarming one. It was a baby of 3 months with alleged reflux and failure to thrive. This is when I was senior registrar in Nottingham, working on the ITU, PICU ITU. So this child had alleged reflux, mother saying regularly bringing back feeds, and was losing weight. So the obvious diagnosis was reflux, but when we did a barium swallow and 24-hour esophageal pH monitoring, where you put a little probe down through into the esophagus from the nose, measuring the pH to see whether there was acid reflux occurring or not. And these were normal. And the baby was an inpatient on the baby ward. The milk feeds were being prepared by the hospital nursing and dietetic team, and yet despite normal feed volumes, the child wasn't gaining weight. This was an absolute conundrum. We couldn't work it out. Then we thought of analysing the milk bottles that the child was having, and they had 50% of the osmolality. They were basically half-strength feeds. Mother was challenged, and she did then admit to opening the feeds that had been pre-prepared in the baby kitchen, adding 50% water, and that was the reason for the failure to thrive. So she was discharged on the child protection register, as was in those days, as a case of Munchausen by proxy. But then, sadly, 3 months later, she was admitted as a query cot death, and at post-mortem, there was evidence that she'd been suffocated. The mother was charged with infanticide, and I was on my way to Nottingham Court. I was about 10 minutes away when I got a phone call from the police officer in the court on my brother's old brick phone, and it said, "Sorry, Doc, you don't need to come. She's just changed her plea to guilty on the first day of the trial." So it just shows that when we have got serious concerns about AFI, we do need to take it seriously, and we do need to act, because the outcome can indeed be fatal. Moving on. Another one from Brighton I was involved with. This girl of 4 was being admitted with hypothermia, very cold, and no cause could be found. She then got treated for narcolepsy when she was getting sudden collapses, and was treated with a stimulant called modafinil, which is the normal treatment for that fairly rare condition. And despite repeated episodes, beside the treatment, there were repeated episodes of collapse. And this was difficult to understand. We're giving the right treatment. Why are these still occurring? A urine toxicology screen was normal, but the child remained sleepy. And again, we thought, what on earth's going on? A further sample of urine was then taken when the mother was not on the ward and was found to have diazepam not prescribed for the child. And what the mother had been doing is, when she knew a urine sample was being taken because she was suspicious that she had already been fingered, she was providing a sample of her own urine, and that was analysed. The GP records of the mother then showed that she had been prescribed night sedation, diazepam, and she had been giving this to the child to try and fool the medics. The reason why the child was hypothermic then was discovered when the child was then carefully interviewed by specialist trained police officers, and she said that her mummy used to say she'd been naughty and would put her in a freezing cold bath water, and then once she was really cold was bringing up to hospital and then ending up with unnecessary investigations. Okay, moving on. Now, moving on to, those cases I've just gone through, they were FII. And I want to stress that FII, the real true blue FII, is actually very rare. These cases are not common, whereas perhaps the perplexing presentations are a bit more common. And examples of where we might be thinking about it, a perplexing presentation, is child said to have seizures by the parents, but they're only ever witnessed by one parent. They haven't been seen. They've never had a seizure in the nursery or in the school or in the grandparents' house or anything. That raises your suspicion. Maybe children presenting with lethargy, their parents saying they're very tired, which suggests they might have chronic fatigue syndrome, or ME, as it tends to be called more nowadays. But at school, the schools say, well, we don't see that. The child gets up and runs around the playground like a good one. And we've got a couple of those cases on the go at the moment in Leicester right now. Maybe also children with reported symptoms of ADHD or autism, but the normal behaviours observed at school. So that's why when as paediatricians, we're trying to make diagnose ADHD and autism, we're always looking for evidence in a different environment from the home environment to confirm that these conditions may be present. And then one alerting sign that something may be going on in terms of this sort of perplexing person is children collecting diagnoses that are difficult to confirm. And these might include headaches, abdominal pain, vomiting, cyanotic when there's apparently going blue. So what we'll always be doing in this, certainly so with cyanotic episodes or with seizures, we'll be asking the parents to, if you had one, we'll take it. Everybody's got videos on their phones now, so they should be able to provide some evidence to help us sort out the wheat from the chaff. And then there's these new sort of range of diagnoses that the clever parents are starting to collect. Ehlers-Danlos syndrome is a connective tissue disorder where you get joint laxity and sometimes breathing disorders and so on. Sensory processing disorder, where it's claimed that the child has problems with noises and textures and so on. ARFID is a very new one that's been described, which is avoidance restrictive food taking disorder, where the parents say, well, the only thing the child will eat is chicken nuggets and chips and won't touch anything else. And as a result, the child is failing to thrive and lose weight. And then the even harder ones to deal with and assess, the regional pain syndromes, where the child is saying he's getting pains in the legs, or the legs and the arms, or the back, the abdomen, and trying to sort out what is real pain and what is maybe just perceived pain, and pain that's not there is very, very difficult to sort out. There is a pain clinic based in the Royal Infirmary, and they do their best to try and work out what's going on. Next one. Now, this is the new thing as part of the new protocol, that when we're looking at these cases of possible FII, but also just the perplexing presentations, we need to establish health and education rehabilitation meetings. The purpose of the meeting is to try and define the child's state of health and areas of continuing uncertainty about what, okay, we may agree that, yes, we can see these things and we agree that they're present, but other things where maybe the parents are saying they've got this or that and the other, and we can't find any evidence from anyone else independently that that's going on. Also to try and work out what is the nature and level of harm to the child, because if the nature and level of harm to the child is serious and high, we may move from the EHRP, H in the ERP, to a genuine FII Section 47 investigation. The meeting should also decide whether to commence a chronology, because these can be very helpful. That when we should, how frequently the meeting should be taking place, and then the really new addition to the whole approach to this is the requirement for specialist psychological therapy for both the parents, the perpetrators, and for the children. And that is something that is slightly holding up the introduction completely of the new protocol. Is we're looking for ways to find these are going to have to be really specialist psychologists who really know what they're dealing with. But we have got an active process going on looking for appropriate psychologists. One case has already been dealt with. In order to get the appropriate psychological support, we had to access professionals who are actually based in Essex. And then finally, any information given to professionals by the parents or carers outside the meeting need to be clarified with the other health agencies before anybody acts on it. Okay, next slide. If the parents agree to the health and education rehabilitation plan and want to work together with the professionals, great. That's the way forward. And we're trying to have, as I said, a non-confrontational approach. We're agreeing with the parents. Maybe we don't understand exactly what's going on, but we're going to work with you to see if we can resolve the problem. However, if the parents are refusing to cooperate with the plan, then it moves on to a situation where we need to inform and refer to children's social care and make sure that the parents also inform that that referral has taken place. Next slide. I think I've just more or less said all of that. I think we could avoid that. Go on to the next slide. Okay. These are I think it's my final slide. These are the possible perceived difficulties that I see with the new protocol. One, identifying the responsible lead paediatrician. That may be because either there are loads of different, sometimes when these cases come to light, the child is already being seen by 3 or 4 different specialists in different specialties. So trying to work out which of those should be the lead paediatrician is sometimes difficult. Sometimes, however, these cases are referred to us to consider whether no paediatrician has been involved at all. They're only seeing people in primary care. So then there is built into the protocol a way of trying to work out who the lead paediatrician should be in those cases. Another thing is finding time for the health professionals to actually prepare unified health chronologies. You might think, well, why isn't it a matter of time? Surely people are busy. They've already got a work plan that is filled up, and then they're asked to create a health chronology. And one case that has become a serious case review in Leicester, the named doctor at the Leicester Royal Infirmary had to produce a 90-page chronology of events, which took her 3 weeks out of her working schedule to prepare, and she was working from about 100 files of medical health notes. So these chronologies can take an awful lot of time, so we need to find ways to give those that are being asked to do them to create them. Arranging the health and rehabilitation plans is going to potentially be difficult. Who's going to do that? Is that going to be the responsibility of the lead paediatrician? Is it going to be social care? As we know, trying to arrange meetings like this is often very difficult because people have got competing demands on their normal working week. Who is actually going to chair the education and health rehabilitation plan meetings? The hope is that the lead responsible paediatrician will be sufficiently experienced in order to take on this role. But we've never held these meetings, and these are going to be difficult because we're trying to hold meeting with parents who are concerned, maybe perpetrators, and with the professionals, and trying to do it. This is going to be very much a work in progress. There may be problems with school holidays because it is education as well as health. If school teachers and school or services aren't available, what are we going to do during the months of July and August, September? And then the final thing, the funding for psychological support, we're trying to identify. It has been taken up by the CCG, and we are actively looking to and the commissioners to get this psychological support funded and to find appropriate psychologists to give it. Okay, next slide I think is the last, isn't it? Yeah.
There are one or two questions in the chat, which I've noticed. The interesting question from Iona: is there any research into why parents would behave in such a way? I know there was quite a lot a few years ago when I was practicing as a social worker, but I don't know.
We do know the classic sort of potential perpetrator. They are more commonly females, something of a ratio of about 5 to 1. They often have come from a medical, paramedical type background, nursing, therapy, whatever. So they've already got a bit of a knowledge of what diagnoses are about and how to access information about them, because part of the problem is if the parents, and of course it's much easier now with Google and Wikipedias and all these things, people can get information about diagnosis and then come along and present the symptoms that a child with that diagnosis would have. And so the medic taking the history in good faith thinks, oh, right, well, yeah, this does sound, it's a case of this or that or the other. We also know that some of the cases are commonly, if we look back at the perpetrators' childhood, they were also presenting at the time with multiple medical problems which were being perpetrated by their own parents. So they come down a family line, as is the case with a lot of child abuse, that abused then become the abusers over time. Another group have been identified by research of parents who may have had maybe a premature baby, been on a neonatal unit for 2 months, watching what's going on, hearing what's going on, becoming really quite medically adept at knowing about symptoms and things like that. So yeah, there is quite a lot of information about the classic type of perpetrator.
So does this kind of issue ever happen with vulnerable adults? For example, parental carers of adults with learning disabilities. I mean, I know from my own experience that it did happen with one of the young people that I was working with, and they, there was lots of intrusive medical examinations which were totally unnecessary, and but yeah, I don't know, Alan, if you've got any thoughts on that.
Well, obviously, as a paediatrician, I'm not involved.
No, I know,
adults, but there's absolutely no reason why exactly the same might not happen with, vulnerable adults and their own carers perpetrating and trying to get things done, maybe to get increased carers allowances and so on and so forth. So yes, it's obviously equally applicable in adults, although I have no personal experience.
I think there's something about, also in my experience, it was about wanting to maintain that caring role, which had become so important. And, you know, as the person got older and they didn't need the care, they were, you know, fabricating it so that they did need it. Anyway,
yeah, that exactly ties in with the classic sort of initial presentation of some of these cases, that the parent and the carers often are presented as fantastically caring and supportive parents, doing their very best for their children and so on. And of course that can hoodwink the medical and other professionals into believing everything they're being told and not having sufficient professional curiosity. We're going back to as to, you know, does this really fit together or not? I mean, it actually goes back to that Brighton case, that if we as part of the kind of collecting the information you require to try and tease out what's really going on, it's always very important to try and get access to the parents' carers' own medical records, and that may be clues in what they're currently being treated for, maybe clues, as I said, when they were children, as to what things that were being done to them, which may well have been totally unnecessary, that were perpetrated on them by their own parents.